everybody, and welcome. Today we're at the Medicaid Innovation Forum in Tampa, Florida, and I have the pleasure of getting to talk with Mike Rapach, the President and CEO of CareFirst Community Health Plan, Maryland. Mike, thank you very much for joining me.
Thank you for having me.
Tell us a little bit about yourself.
So I started CareFirst about a little over 3 years ago. Took over as the CEO for the Medicaid plan, since have taken responsibility for the Medicare businesses. But I've also been in the industry for about 20 years, working for a number of the national players in Medicaid and Medicare, the Affordable Care Act, commercial business, kind of everything you can possibly do in insurance.
So CareFirst in particular strikes me as extremely innovative. The number of partnerships, whether they are with vendors or through the innovation arm, through the investment arm, is impressive. Tell us a bit about why there are so many of those concepts targeting the Medicaid population specifically.
We find right now that Medicaid is a very interesting space for a number of small companies trying to make a difference in areas like social determinants, in areas such as medication adherence, a whole host of options. And we're interested not just in trying to find services that create benefit for our members and help improve their health, but also as an organization looking for companies that we can get in early with, create some investment opportunity, see their growth, and also participate in some of the future of those organizations as well.
It's been really excellent for the Baltimore ecosystem in particular, having a large health plan that supports local companies. For us, for Scene Health, CareFirst was our very first health plan partner. We had, at the time, this was 2018, 2019, we had expanded through public health departments all over the country, but we didn't understand health plans. And I feel like we were truly incubated. Tell us about the partnership with Scene Health, what it's meant to CareFirst, and your membership.
One of the best things about our partnership with Scene Health has been the learning what is important to our members. And how are they going to be engaged in terms of really understanding their medication, understanding their challenges. We hear a lot of things at a high level, but we never really get a great sense at a detailed level as to why certain members are having certain challenges with what they're doing. And when you look at our market and you look at Maryland, it's a wide variety of people with a wide variety of challenges. Being able to get down into a lower level of understanding is really important. Primary care can't really solve everything we'd like it to. It can't support a member every day and answer their phone calls and answer their questions about their medications or how to use it or why to use it. And organizations like Scene can really help us do that at a much more granular, effective level.
Right, I think there's always that tension between population health strategies, big strategies, maybe assumptions made about what would solve a problem as complicated as medication adherence. But when you boil it down to the individual level, take something like asthma, a kid trying to use an inhaler, the barriers, as you were saying, or their challenges are always pretty specific.
Oh, they are. I actually grew up with childhood asthma. And
I didn't know that.
Oh, yeah. It's a family condition we all kind of go through. But watching the one video shared with me of one of our members working his way through learning how to use an inhaler, learning how to kind of overcome the challenge he's having, it kind of brought me back to,
Wow.
Being 14 years old and getting my inhaler the first time. They were a lot more clunky then, but being able to have the ability to breathe at night, being able to have that positive impact and having an organization you can reach out to when you're sitting there going, I don't know how to use this and I don't feel well. And being able to get a response, being able to get assistance, being able to have a really strong impact on your health right then, that's fantastic.
Yeah, I think what people always assume that the problem with adherence lies primarily in behavior, meaning forgetfulness. That's the obvious thing. Well, if we could just remind people, then the adherence challenge would be solved. But in the case of asthma, as you know firsthand, I see it almost more akin to like learning a mechanical skill or even a sport. We've seen that especially in Medicaid, that 9 out of 10 kids are not using the inhaler correctly. And that means that the medication's not getting into their body, which means that these very amazing medications are just not, they're being paid for, they're being delivered, but they're not always being useful.
Yeah, asthma, diabetes, a number of chronic conditions. If you're able to keep up with your medication, maintain it, refill it, do the things you're supposed to do, are very manageable. And we all have them. We all have these challenges, whether we're young or we're getting older. We all have a new medication we have to start to take that our doctors recommended. Being able to keep up with that, understand the why, understand the benefit to us by just maintaining that medication day after day, month after month, and having an organization to support us to do it, is a real win. It keeps folks out of the hospital. It keeps them from having acute visits to an urgent care. It keeps them from being stressed out. It's a really wonderful thing to have and to be able to support them.
And as you said earlier, that's not something necessarily that we can expect out of our primary care system. So we're going to get to that part of it. But maybe the prerequisite here to delivering a system such as ours, or the many innovative concepts that you have in the Medicaid line of business, is being able to engage with the member. And in Medicaid, that can't be taken for granted. It's not that easy. What are the challenges you've experienced? Some of the solutions you've seen working?
When we look at the Medicaid population, one of the core challenges that they have is a lack of time. You're talking about individuals who are commuting to their jobs usually on public transportation. They may have multiple jobs. They may have childcare and other challenges, complex family lives, all kinds of things going on. This is a group of people that is trying to keep up every day, and they don't have a higher income that gives them the ability to buy time, like many of us do, of being able to pay somebody to deliver something to our house, or pay someone to take care of their laundry or other things that they might be able to do. That's just not available to them. So we have to, one, understand how to reach them and reach them effectively where they are. That's hard to do on the phone, that's hard to do via mail, that's hard to do via text, because we have to catch them with something that's meaningful and important to them. And so we're constantly trying to find the right mechanism to reach out to these members and to see where they are and give them a reason to call us back or email us back or text us back, whatever works for them. But it's really trying to find them where they are at that time and being respectful and understanding of some of the challenges that they're having, trying to figure out how we can do it asynchronously, trying to figure out how we can do it when they're ready to talk to us.
It really speaks to having lots of different ways to communicate. I've seen, and we've actually participated in some of CareFirst community events. So I know that from the ability to reach somebody on the phone, to actually see them in person, to also deploy a video solution which works asynchronously, it seems like CareFirst tries to stay broad in all the ways that a member might want to communicate with the plan.
Absolutely. We have to try everything. When we went through our redetermination work recently, we did a lot of focus groups and just talked to members and said, what would be meaningful to you? What do you understand about the program, the plan, the approaches that we're taking? How can we help you understand this better? And that was kind of the first step of just getting a basic understanding of where they were, what they knew, what they didn't, what communications had actually been reaching them. How do we get good addresses, good phone numbers, good sources of information? All of that's a challenge in the Medicaid space. The rule of thumb in the industry is about a third of the phone calls you make may get answered.
Right.
And that's mind-numbing when we think about other populations that we'd be supporting. The idea that we're only going to reach a third of them, and then we hope about half of those actually call us back. So now we're really trying to find every possible way. So community events and texting and whatever else we have is so key to just being able to create some level of communication.
One thing we found in the early days, we were compared to telehealth, and the industry didn't know how to bucket us. So telehealth was the convenient way to do it. And so we used the word asynchronous, which just means not at the same time, obviously. But that word is quite bulky and hard to understand. So the way I best explain it is a way that you actually explained it back to me in an earlier conversation. So telehealth takes away the geographic barriers between, you can serve someone in a very rural part of the country, very far away from a central location with telehealth. It's synchronous and it's video. But asynchronous video has the added benefit of removing time constraints.
Yeah.
So you can meet somebody, but you can do it at different times. How's that? How do you see that playing out in our work in medication adherence?
I see it really having a great benefit. Some of the videos that you were sharing with me earlier this week of just showing our members every day reaching out and saying, hey, by the way, took my meds. And I'm taking this med, taking this med, taking this med, and they're bouncing up and down. They're having a good time, older people, younger people, but they're engaged in the process because it's not us forcing them to do it at a certain time in a certain way. It's allowing them to have the freedom to manage their lives, giving them the respect to manage their lives, and then being able to say, just let us know you did. Want to know you took your medications, want to know everything's going well. If you have a challenge, great, say something. But the ability to just capture that in a time frame that works for them and gives them the freedom and the respect to do it well is fantastic.
Awesome. So it's very important for us to maintain that personal touch that you're referring to, and we do that by making sure that we send videos right back to the member. And in some of the videos I showed you, your care team was actually sending videos back in to your membership. And I think one thing our care teams have in common is this compassionate ethos for the membership. What's the secret sauce, if any, there that you can tell us about?
We talk a lot about our obligations. In my mind, for our Medicaid and Medicare population, we have three of them. Our first obligation is to our members, giving them the services, the benefits, the support that they deserve, and making sure we deliver on that promise. Our second is to our regulators, who in many ways are our customers. CMS and the Maryland Department of Health are the ones telling us what's expected, giving us very complex expectations, and expecting us to deliver on every last one of them to benefit those members. And so we view that as a very strong obligation. And then third is our obligation to CareFirst in totality, and making sure that we're representing the brand well, we're delivering the expectations that the organization needs, and supporting a good, solid base of health across our service area. When we talk about our obligations to our members, our quality team, our enrollment team, our member services team, they talk about our members as their members. Right. Our enrollment manager constantly talks about her members, and let me tell you, she means it. If their cards aren't out right, if their support isn't right, if they're not getting what they need every day, it hits her. Our quality team, they care immensely about making sure that every person they're reaching out to is getting what they're supposed to get. And not just because we have a box to tick, right, but it's because their health matters. Their life matters. We want to make sure that we're truly supporting our members where they are and getting them the services and the benefits that they need. Right.
And I really feel that, whether it's the care team, the case management team, the quality team, I think especially on the quality team, one thing I've noted is when we talk about strategies for a particular metric, they're always making sure that the intent behind that HEDIS metric is understood. So for example, the annual wellness visit or the well child visit, we are always reminded by your team that the purpose of this is that when people get to the provider, they tend to be healthier, right? It's more when they pick up their medication, they're more likely to take it. So I love hearing the clinical intent or the benefit to the member behind anything that's being done. It's the right way to do business, I think, because in the end, CMS has laid out this roadmap in terms of quality based on clinical benefit to the member.
Yeah, when we call them quality measures, it's intended to say that we're doing the right things for our population. It isn't intended to just be something where we get a score, because the quality is intended to measure the quality of care. Right. Not just to say, yes, we had 87% of our people refill their statin medication. Great that we did. Are they taking it? Do they care about it? Do they understand it? Do they understand the rationale behind it? That's actually delivering on our brand promise and making sure we're helping people get better in their health.
Right. Now, speaking of medications in particular, pharmacy costs are only getting higher. It's not just the specialization of certain medications and their cost as they come to market, but it is also the fact that CMS it's probably about now 10 years into a campaign to make sure that people have access to medication. How do you think about pharmacy spend going forward as it becomes an increasing part of a Medicaid and Medicare budget?
I expect pharmacy spend will continue to rise, mainly because if you look at some of the amazing drugs that are coming to market, the drugs for sickle cell anemia, the drugs soon to be for weight loss, a number of what we saw with hepatitis, they have a dramatic impact in really making people healthier, changing people's lives. I've talked to some of the providers about the sickle cell drugs, and they're saying, yeah, they really do work. It's amazing. And so we have this ability to really impact someone's life for the long term. If we can get them to take the medication, follow the treatments, what we've seen with HIV has been just a godsend in being able to change the entire trajectory of that disease. It's now something that can be maintained and supported, but it's complex. People need to stay on the medications. They need to take it seriously. They need to understand the nuances of it. Every way we can help them maintain those drugs, maintain their treatments, get refills that they're supposed to do, and stay on top of that every day, allows us to keep people out of the hospital, keep people out of much more complex medical situations, and have better lives.
It's incredible to me that it takes a real effort to explain, generally speaking, what you've said right now, which is that medications can have a tremendous benefit. And that's being said in the context of these refill metrics. Mm-hmm. And the words medication adherence in the NCQA or CMS lingo, they actually do refer to the proportion of days covered or the refill rate. Mm-hmm. So it's incredible that we have to re-educate the public that the real measure of whether someone is adherent is the extent to which they're taking their medication. The opportunity, though, is that, like you're saying, HIV can be completely managed and life expectancy can be on par with somebody who doesn't have HIV.
Yeah.
If you take hydroxyurea for sickle cell disease as a child, you can prevent the sickling of these of the cells. And for hepatitis C, there you have a total cure. And I think I was actually looking at this the other day, the difference between somebody with hepatitis C in terms of inpatient costs mm-hmm. versus somebody without, the difference is about $17,000 a year. And that's with the drug priced in.
Yeah.
So there is a huge opportunity, and actually it's not just an opportunity, it's probably an imperative at this point, given how expensive drugs are.
It is. 10 years ago in this industry, all we did was talk about the hepatitis drugs and the massive costs that they were going to have. That isn't even one of the top 10 spends we have now. Right. It just went away. It dramatically went away because we had medications that could change that trajectory. HIV for us is still, it's a lot right. of expense, and but it's dramatically impactful to people's lives. But those drugs are complex and they require a lot of management and oversight. I think that's where we're going to see the pharmaceutical industry going. They know they can have an impact to someone's life. They know that it's going to be very difficult for us to say no because of that impact.
Right.
And now we have to figure out how to make sure if we're going to spend the resources and the time and the investment to make those drugs available and have someone take them, that the health outcome comes on the other side. And so medication adherence, which is such a clinical term, but it's the term we have, just making sure people really stay on their meds, use their meds, understand their meds, and are supported by the community, whether it's the providers, whether it's the health plan, whether it's the overall community of individuals working with them, whatever we can do to keep them healthy, to keep them on their medications and feeling supported and understanding them, it's a great benefit.
Okay, we've talked about how hard it is to engage in Medicaid in general. We've talked about various formats. Mm-hmm. There is at this point I'm going to call it a myth based on our work together, that the older population, especially dual special need plan mm-hmm. members, lots of chronic conditions, lots of medications, that they're very difficult to engage. What do you think?
I would say our older population loves to be engaged. We constantly see in our member services area and our call center individuals calling in all the time. And we know who they are. We know who those members are because they want to talk to someone. They like to talk to someone. They get to know people. It's a way for them to feel part of the world and feel part of the community. And so we see the same thing in technology. We see the same things in pretty much every mechanism. The population that's 60 and over is very familiar with technology now. The pandemic changed that dramatically. And even before that, the trend line was up. The pandemic just accelerated it. So they're all used to communicating with the grandchildren. They're communicating with their families. They're communicating with their friends. All of them through technological means because that's what was available to them for 2.5 years when they couldn't do much else. And so we don't really see that as a challenge of getting engagement. I think it's more of a challenge of making sure the engagement's the right engagement and that we're talking to them about things that matter, things that they need to understand, and not spending a lot of time just kind of feeding them the same types of things that health plans have in the past.
Right. Yeah, we noticed with the uptake of asynchronous video or video recordings that probably two major events in our 10-year history were the rise of Snapchat and Instagram and Facebook and using video recordings. But the second was the pandemic and I would just say the forcing function into video. I would agree that engagement has to have a reason and a goal. Of course, one goal can be to open up a channel of communication. That's valuable. But some of these videos, which we're getting, let's say for people with hypertension, they're very, very long because they go far off track. But that's also the magic of asynchronous video, that you can just reply having acknowledged that you've seen something, correcting something small that needs correction, and then moving on. But I agree that engagement needs to be goal-oriented for sure. Otherwise, what's the point?
Absolutely. You're trying to take someone's time and you're trying to encourage them to do an activity that they may not understand or in some cases may not want to do. But you've got to encourage them in the right direction. And so all of this is trying to educate, trying to support, trying to spend the time, but also with the idea of respecting that someone may have something else that they want to do with their time.
Right.
You know, talking to us is one thing, talking to their grandkids is another thing.
Right.
So you can see where we might rank on the priorities.
Right. While we do get a wide range of topics, the sheer number of medications does cause confusion in the polypharmacy population. We find that sorting out that confusion takes several days at a time. But at the same time, I have to say that our care team really gets a lot of pleasure out of speaking to really, really wonderful people, and that's part of the experience, I think, from our side that makes it so much fun. So we were talking earlier about quality metrics, goal-oriented engagement, and something that you had mentioned to me earlier is that we really are putting a lot of demands on primary care, bricks and mortar facilities to deliver a lot of what we would call the standard of care. And we know that in-person care is under a lot of pressure right now, whether it's staffing shortages or just simply the amount of time they have to meet with a patient. What do you see in terms of like the role of a Scene Health or your other innovative partners working within this let's call it the tension between primary care and quality?
When you think about primary care, right now you're seeing your doctor for 5 minutes, you're seeing the nurse for 5 to 10 minutes, you're in the waiting room for 30 minutes or an hour. And so your time with clinicians, your time with the actual support mechanisms is very little. And then you leave. You've got this piece of paper, this stuff they printed off, maybe some prescriptions that you've been given, maybe they send them to a pharmacy. And often you don't have a lot of good information. Now you're going home, you're trying to remember everything they said because they talked fast and they sent a lot of things to you and they gave you a whole list of things. Now you got to read this document that was half written by the lawyers and half written by the medical professionals. And where do you go? So you can call your primary care physician and their office will get back to you in a couple of days because they're trying to keep up with everything they've got going on, and it's a challenge. Or you can leverage the tools that our health plan may provide, like Scene, and give you some place you can reach out to much more quickly and get a faster response, get support, get longitudinal support, which isn't just, one time we'll answer your question and send you off, but every day we're going to be there to kind of boost you along and get you into that habit. give you that time and ongoing time to build those habits and get you comfortable with the drugs, get you comfortable with the treatments, the processes, when to use them, when not to use them, how to measure various things to see how much of something you might need. It's a lot of complexity. And if you take the time and educate someone and be patient with them and let them come to it, you're going to see great benefits. One, they'll get the benefits of their health. Two, their level of demand on the healthcare system won't be as bad. And so those primary care doctors can be spending time with folks who might be in a little bit more of a difficult situation than they are.
Right.
And it keeps them out of the hospital because nobody wants to go to the hospital. And if we can do anything to keep people with chronic conditions from those becoming acute conditions, then that's really a great thing. And so that takes education, that takes time, that takes
Right.
patience, that takes understanding and empathy. It takes, speaking to someone with faces and experiences and livelihoods that they understand, who understand them. It's all a complex thing, but it's slowing down enough to understand the person, slowing down enough to understand what their real challenges are, and then helping them solve it one step at a time until they're getting to a point of self-sufficiency and comfort.
I really like that answer. To me, it says we need more time with people, and we're not going to be able to deliver that in the current primary care environment for various reasons.
Right.
And in the hospital setting as well, length of stay has been a major metric that's been worked on for decades, with the disadvantage that you don't have as much time with the patients. So what I hear you saying is we can take that time in between and augment and support those primary care efforts. We always see ourselves as delivering on the physician's order. Physician said, this is what you should do, and we're helping that along, because as you say, discharge is not the best place to educate somebody. So we talked earlier today about how CareFirst handled the wind down of the pandemic redetermination, which was a major challenge for health plans all over the country. And it seems like in Maryland, there was a really, really concerted effort to handle this in the best way possible for members. How is CareFirst doing now that most of that effort has happened?
I'd say we're doing pretty well. First, though, I'd really want to call out the partnership with the other managed care organizations in the state who also support the Medicaid population, with the Maryland Department of Health. All of us work together very closely to try to maintain Medicare eligibility for as many people as we possibly could. And so what we've seen in Maryland is probably a smaller reduction in membership losses than many other states. We've been really happy about that. When we look at it from the CareFirst perspective, we've seen our membership grow. Not many managed care organizations would be able to see that. We saw about a 9% growth in 2023 when the market shrank about 5%. And we view that as kind of core to a couple of things, those obligations I was talking about earlier, us giving our brand promise and then us delivering on that brand promise. Individuals in Maryland who are on Medicaid eligibility have the ability to change their plan once a year. And what we are finding is that they're coming to us when they join or when they have the opportunity to change, and then they're not leaving. That next year comes around, they're staying. They're staying with us because the promise we made at the beginning is the promise we're now delivering in terms of service, in terms of support, in terms of everything we can possibly do in healthcare within the constructs of the model we have. But we're delivering on that promise. And so we're seeing the Medicaid eligible population in Maryland make the decision to stay with us.
Wow. So CareFirst Community Health Plan actually grew through redetermination?
We did.
Incredible. Has that led to, is it Medicaid expansion in Maryland?
We've captured probably what would be considered a disproportionate amount of the share. The market grew a certain amount, we grew a great deal more. Since we took over the plan through the acquisition we did at the end of 2020, we've grown our plan about 83%.
Incredible.
It's been fantastic. And that's really due to the hard work of our team, hard work of our service organizations in quality and member services, working with the providers. Pretty much everyone is dedicated and focused on the goal of making sure that the plan is effective and that we're delivering on our promises. And so, with partners like yourselves, with our internal organization, with the rest of CareFirst, we're able to do it, and we're seeing the results.
Well, congratulations.
Thank you.
Thank you also for taking your time for me.